Welcome everybody to the March, I had to check what month we were in, March meeting of the Primary Care Commission Committee. Good to see you all again after a break of a month. Just a reminder, this meeting is being recorded and it's going to be put on YouTube afterwards. So I would be grateful if people didn't use the chat button because things could go be posted later on. So if you've got a question, please just ask. And if you're not speaking, just mute your mic just to reduce interference. And if you could turn your camera on as well, so I can actually see faces rather than lots of blobs of initials, that's helpful as well. So thank you all very much. Good to see you all. I took a chair's action in terms of the funding for rollout of the vaccination to learning disability groups. There was such a short time frame and it was something that was put forward by NHSE and I didn't think it was contentious, so that's what I did. Apologies for absence. We've got apologies from John England, Jill Jones, Tony Goldston, Kerry Overton and Thomas Iyer. I think that is all. And the declarations of interest, I just remind everybody to keep their declarations up to date. And are there any declarations today on any items on the agenda? Karen? You're on mute.
Sorry, Doris, my usual conflict of interest, and Tracy Rogers will be taking part 2. I'm conflicted.
Thank you. We move on to the minutes of the last meeting. Are there any factual inaccuracies anybody wants to raise? The only one I had was in relation to is on page 7 of the pack under the prescribing report. In the minutes it said a letter had been sent to Targeted Practice. I think we were planning to send it, but given the challenges primary cares have currently, we've changed it to not send that letter out, but to ask the local partners to actually have a chat to the practice managers, and then we can always come back and revisit the letter if needed once things return to the new normal, whatever that is. So that's just a slight change in the minutes, so that's not accurate. Are there any matters arising that are not on the agenda from anybody? Hein?
Thanks, Doris. In point 9 of the minutes, I was triggered. We had a discussion whether the process could be lengthened. That was raised by John Ingham, and that was going to be followed up. Now, there's no action for that, but I was curious if anybody knows whether we've been successful in extending that process that's been described.
Sadie?
I'm sorry, I can't see if I've got a finance colleague on the meeting, but we have had a discussion around this, and we are working with the primary care networks now to go through their high-level plans so that we can provide those to the internal auditors as part of the piece of work that the finance team will be doing. As far as the 2019-20 budget for PCN development goes, I think there's a general understanding that that won't be able to be carried forward, but actually most of the PCNs are on track with finishing spending that off anyway.
Okay, thanks.
So are you happy, Hein, for that to?
Yeah.
We don't need that on the action log for going forward. Okay, great, thank you. That takes us neatly onto the action log. And there is just one item on there, which is the terms of reference, which is on the agenda later on today. So that should be able to be closed off after today's meeting. Onto the forward planner. Sorry, I'm kind of, planner is not on the paper I'm looking at, but it's on the list. Any help, Sadie?
Yes, sorry, I just spotted that before we started, that it didn't seem to be uploaded to Diligent. Apologies. This is our first month at managing this one. I mean, as you know, Doris, and for the benefit of other people here, because of the ongoing impact of the pandemic, we had tried to limit today's meeting to essential items of business only. We can circulate the forward planner, which just notes that after the meeting, and we have started working on revised planners for next financial year, assuming that we can start returning to business as usual. But so we will obviously bring those to our first business as usual primary care committee for people to review.
Thanks, Sadie. It's the joys of new technology, and yeah, we're all kind of getting to grips with it, isn't it? It's good to keep me on my toes to see that I've missed something or haven't missed something. On to the next item is the risk register. And I think there's been an updated paper on this one. Do you want to just take us through this, Sadie? I think that we agreed at the last meeting that we kind of concentrate on the sort of red risk and not worry too much about the other ones, given the constraints the team have got. So over to you.
Thank you. We took on board the really valuable feedback that we had, thank you, and therefore you will notice changes in red, just more generally on the register first, which relate to the scoring, where the scoring had been done the wrong way round. So you'll see that none of the totals change where that's happened. It's just that the multiplication had been done the wrong way round. So that is now correct in terms of how it's presented. We have 5 red risks on the agenda, and these relate to the project around the locally commissioned services, the delivery of learning disability health checks, which has been particularly impacted by the pandemic, the prescribing risk around hypnotics and anxiolytics, the process of recovery in general practice, and then PC14, the access to general practice and how that's been impacted, and the potential system-wide pressures that could potentially cause. You'll see that there are updates in red against each of them. The PC14 risk, we've left the scoring as we had originally set it. However, I think we may see that one starting to come down. We do have to wait and see what the requirements are from NHS England nationally in terms of business as usual. But given the success of the vaccination programme and the high take-up that we've seen amongst healthcare workers, I think some of the impacts that we've seen around workforce and staff absences, for example, we are seeing start to stabilise, but we've left the scoring as it is because we're not yet sure what the national requirements are going to be around standing up business as usual and what the timelines will be around that. There is one risk on here as well that we are proposing to close. and that is the flu risk. Whilst we're still seeing the odd patient pitching up, asking for a flu vaccination now, the season is largely complete, and we've had a fantastic flu season thanks to all of our providers. This will likely come back again in the autumn as we start to gear up for the flu season again. But for now, we're proposing to close that risk and take it off the register, as it has met its target score, and the amount of work ongoing is pretty minimal now. So I'm hoping that members will support that, and also very happy for I or any of my colleagues who are perhaps more versed in some of these risks to take any questions or comments.
Thanks, Sadie. Were you planning also to combine the PC7 with the PC14 about ability to deliver full service with the stand-up and combine that as one going forward?
Yeah, I think that would be sensible if members are in agreement with that as well.
That's great. Naomi?
Hi, thank you, Doris. Just wondered if you could just raise an item from PC3, which is on the LCS review, just to say that it refers to there being an hypertension and an AF LCS being looked into, but the LMC hasn't been shared either of these specifications to consult on. So if they're aiming to be out in April, can I please ask Sadie to take forward that we need sight of them, please? And
Thanks.
in addition to that, it's just sort of linked in with the same, but on PC11, again, around LCSs, there's a discussion about phlebotomy. I mean, we have been in discussions with the CSG for a while on phlebotomy, but are very aware that a discussion took place around there being inconsistencies in how practices are funding for carrying out bloods on behalf of secondary care within the LCSs, and that there was a piece of work that was due to take place to ensure that practices were funded and that this was consistent. So really would appreciate an update on where the CCG is on that piece of work, as well as what the options are if practices are unable to take secondary care bloods, and where the piece of work on prioritising the phlebotomy LCS has got to, because previously that was seen as one of the priority LCSs but isn't included in PC3. And then finally, just please can we ask for an update to be given to practices on LCSs from April, as to date we're not aware practices have been informed on what will be happening with LCSs from April onwards.
Okay, thank you. I'll try and remember all of that, but you might need to remind me. If
we can discuss tomorrow, Sadie, if any of those things are forgotten. Thank you.
In terms of phlebotomy, secondary care phlebotomy, John Webster might be in a little bit better position than I to update on that, but I know that Mark Lim has begun discussions around secondary care phlebotomy and the pathway around that. Don't know if John wants to come in.
I don't have anything to update beyond that, actually.
Okay.
So yeah, I know that that's work in hand. I've also met recently with Tim Barger from the LMC, talking about the principle of secondary to primary care shifts of activity as well. And we've agreed a way forward, particularly in relation to West Norfolk, in relation to those issues. So it is very much work in progress, but you're right, Mark is looking specifically at the phlebotomy pathway, Sadie. Thanks,
John. In terms of primary care phlebotomy, it is, I don't think the position has changed in that we're still concerned that there are differences that we've inherited from 5 former CCGs, and if the pandemic hadn't have been with us, we would have hopefully have sorted all of that out by now. But unfortunately we haven't yet, and I'm very conscious of the fact that March is the end, the end of March is very, very close. Mark and I met to discuss this morning in terms of taking that forward, and whilst I don't have anything concrete to share this afternoon, it is something that we are now prioritising as part of our recovery planning. So I hope that we'll be able to give the LMC updates through our weekly meetings with them, but also bring an update to the committee next month as well. And obviously, if we need to take any urgent action around contractual matters, then we will seek Doris's advice on how to take that forward in between meetings. The AF and hypertension LCS, that is something that I haven't been involved with, and it might again be something that is being led by the planned care team. We do have a colleague from the planned care team coming to brief the primary care leads next week. So we'll make sure that we get an update, and we certainly wouldn't be issuing anything out to general practice without going through the proper process of engaging with the LMC first.
Parveen, did you want to come in on that one?
Thank you, Doris. So with the AF and the hypertension, it's something the planned team have approached us about, because it's again one of the areas of disparity across the 5 CCG. So we're not in a position at the moment to have a finalised or a draft spec to share with the LMC. Obviously, once we're in the position to do so, of course, we'll do our normal consultation with the LMC. So I think the April timescales quoted on that is probably a bit ambitious at this stage, so we'll probably move those forward. But at the moment, it's just in the early stages of discussions with the planned care team.
Thanks, Parveen. Tracy, did you want to come in?
Yeah, I was just looking at MP primary care risk 7, and it's just that risk of primary care being able to deliver full services during the coronavirus pandemic. But I think that's slightly changed in some ways now, because just thinking what Norman was saying about some of those LCSs, but also I've just been on the NNN lunchtime call today, and there seems to be some shift in some work from secondary care to primary care, kind of adding to pressures. And I just think the impact with the COVID vaccination programme continuing, and clearly more primary care services coming online again, there will be added pressures. So I'm not sure that we're reflecting that in here. So it might be an adaptation of that risk slightly. Don't know, just something that occurred to me.
Maybe that could be picked up when the two are combined and more robust coverage going forward. That would be good. Are there any other comments, questions from members on the risks? No. And are we happy for the suggestion to close off the flu vaccination and to combine the two primary care risk around access and service as suggested in the pack? Yeah. Excellent. Thank you very much. On to the finance report. Again, we've got sort of updated papers came to us with the actual finance pack in it. So, Jason, are you taking this one?
Yeah, absolutely. Thanks, Doris. Yeah, so the report is in the pack. It reports the month 10 position. We're currently working through the month 11 position as we speak. So that's why it's a month behind, effectively. All comparisons are based on the November advised allocations, and this is showing that we have an underspend of 0.8 million anticipated for the full year. This is mainly due to the release of prior year benefits in both delegated co-commissioning and the reduction of the accruals within locally commissioned services. Within delegated primary care, the forecast is that we will be 1.3 million underspent, predominantly benefiting from lower rent and rates costs in 1920 and from quality outcome framework payments, which we had to accrue at year end, and the actual estimates coming in significantly lower. There still remains a financial risk regarding GP prescribing. Current forecasts are showing at 1.8 million overspent, and this is very volatile at the moment, and we base it on previous months' spend and it is always 2 months in arrears in terms of the data that we get to enable us to provide that accrual, but it's based on the latest information we have. Moving through the pack into slightly more detail, we have a slide on the COVID costs. As reported in previous months, the only COVID costs we're now recovering are staff costs, and this is in line with the national guidance and maintains in the month of January. It's similar levels to the previous month, and we haven't claimed any other costs other than staff costs back since the first half of the year. There's also a slide in relating to PMS and GMS transfers, and this, I believe this was requested at a previous meeting, so we've included that for completeness. And finally, moving on to the financial risks, we're at a bit of a crossroads now. So these risks, a lot of them relate to the 2021 financial year. As we've stated, we're looking to be underspent for this year. And I think these risks will transition over the coming months to look forward rather than backwards into 2021, look into 21-22. And we're still awaiting clarity on the financial arrangements for 21-22, with the current guidance being that Q1 will be a rollover of the second half of 2021, and we're looking to get further detailed guidance on that imminently. We'll report back as soon as we have that detailed guidance. Can I open up to any questions?
Naomi?
Yeah, I just wondered, I did speak to John Ingham about this last month, but just for further information, really thought it might be helpful under the section on GP forward view money to actually separate that out into the different funding pots that are available to general practice, so it's a bit clearer what the total pots are and how much have been spent of each individually, rather than put it as a collective GP forward view funding pot.
Okay, we can do that. Yeah, it's just some analysis. So yeah, I'd say that as an action.
Thank you.
Are there any other questions for Jason? No. Thank you very much for that, Jason. And no doubt there'll be more guidance coming forward in the next couple of months as to what's happening in 21-22. But at least we have some clarity in terms of the first quarter. It's just the rest of the year, isn't it, that we need clarity on. So thank you for that. Moving on to the prescribing report, Michael.
Thank you, Chair. I'll take the paper as read, but I will just highlight one or two things on page 2. Our benchmark spend, which is spend per normalised patient, so normalised for age, so a more elderly population means that patients need more medicine, so you tend to spend more. We're 4th out of the east of England, but that doesn't take account of deprivation, and Norfolk and Waveney has higher deprivation scores from some of the other CCGs. Section 2.3, just one thing to highlight there, category M, which is the mechanism that the Department of Health uses to take money out of prescribing spend on various generic drugs by increasing the price of them or decreasing them occasionally, but mostly increasing them. The cost pressure for the full year is about £2.7 million, and for January, February to March, it's increasing from 144,000 a month to about 327,000 a month. So that's in terms of Department of Health cost pressures on prescribing. And on the following page, I've listed some of the significant areas of growth, which I think Jason mentioned in the finance report, sertraline particularly, which is the antidepressant commonly used first line in anxiety, which has definitely increased in volume during COVID, but the price also went up by £6.76 a pack, giving us a cost pressure of £2.2 million on that one drug alone. And as I've previously mentioned in previous months, our DOACs, which is the alternative to warfarin for anticoagulation. One of them gives us a cost pressure alone of £1.1 million because of a move away from warfarin INR testing to DOAC testing, which is perceived as safer for some patients. In terms of dependence-forming medicines, the usual indicator for high-dose opiates isn't available at the moment, as I've mentioned on one of the pages, section 3.3. So I've reverted to one of the other national indicators, which is high-dose opiates as a percentage of regular opiates, and we're actually 107th out of the 134 organisations on open prescribing now. And the one that remains an area of concern is the hypnotics and anxiolytics, hence it's in the risk register, so we're still the third highest in the country on that one. We are not in the paper, actually starting a pilot on discharge pain relief at the James Paget, which I'll perhaps talk about a bit about next month, which we might roll out across the system if it's successful, which will reduce the need for GPs to continue to prescribe and limit the amount of pain relief that patients get on their discharge after minor procedures or surgery. Just to mention on antibiotic prescribing, so I've highlighted the areas that are the highest prescribers. Something that we did predict to a certain extent would slip during COVID, and the use of online consultations means that GPs threshold at which they prescribe an antibiotic is probably lowered because patients can't get a full examination unless they're invited in, which is not so often. So I've listed some of the practices. So these data are freely available on open prescribing in the public domain, and we'll be talking to the ADs about the associate directors for these areas to mention at practice meetings with these practices, just to raise the issue rather than write formal letters, I think is what we decided. Any questions?
Any questions from Mike or from anybody? Andrew?
Yeah, Michael, I just remember I've got a Health Watch hat on for this.
Yes.
Wondering if you take a sort of a broad whole system view of that, particularly thinking of opiates and benzodiazepine prescribing, because from my conversations, a lot of this comes from secondary care clinics, from pain clinics, but also from non-specialist clinics, so neurology in particular, rheumatology, orthopedic clinics. And is there the opportunity to discuss it with those people who are not necessarily prescribing but recommending medication?
There is. We are going to be talking to, there's a formal medical directors group in the next few weeks, which is part of our system leadership across the STP ICS, as it's now called, Integrated Care System. So we will be talking to them and highlighting the issue to the medical directors who should be taking a lead on those things. It'd be useful if there were particular issues, if we could get evidence of some of those, because with the best will in the world, the medical directors may not be aware of individual approaches from clinicians direct to GPs, or we can ask GPs to advise us if there are some particular themes. On the whole, pain clinics are reasonably on message now, and that's why our prescribing is coming down quite significantly compared to national, and it is going down nationally, because the whole thrust of chronic pain relief is that we don't use opiates particularly anymore for chronic pain relief, and that's just used for acute pain. But that is a good point. If there are coming out from other clinics, then that's something we would like to know. Certainly some of the prescribing is historic, so the benzodiazepines is quite historic, but there are patients who are, it's not easy to get a patient off of a benzodiazepine when they've been on them a long time. So that is an issue that will be more of a longer term project. We do have a dependence forming medicines working group, steering group. We've only met once so far, and we've got another one in the diary. I mean, if you want to come along as a Health Watch representative, then you're more than welcome. If you can get some evidence of particular issues, that would be really good.
Yeah, sure. Yeah, we'll try. It's a bit tricky at the minute, but
it is. Sure.
Great. Thanks, Mike.
Okay.
Karen?
Thank you ever so much, Michael. It's just really to say that senior nurses for primary care will be very happy to join any of those meetings, Michael, as we return to some semblance of business as our new normal, because I'm very keen this is work we were focusing on jointly with yourselves prior to the start of the pandemic, and I'm really keen to pick that back up again with them. So please let us know and we'll get them there. Thank you.
Excellent, thank you.
Are there any other questions or comments, Michael? Is that an old hand, Karen, or a new hand?
Old hand, sorry.
Sorry, disappeared and came back. Thank you very much for your update, as usual. We look forward to the next instalment. On to the terms of reference. Is Amanda joining us for this? Ah, there she is, like magic. She's appeared.
Hello, sorry, I hope I wasn't keeping you waiting.
No, you arrived just as we got there. I think you are psychic, so thank you very much. Do you want to just highlight what you want to highlight on the terms of reference?
Yes, thank you very much, Chair. The terms of reference were presented to the Primary Care Committee at its meeting on the 12th of January. Since that time, there have been just a minor tweak, really, to clause 29, which concerns confidentiality. And this is following discussions with the local medical committee, where they wanted to ensure that and not only members were protected or had to comply with confidentiality requirements, but also attendees. So the clause has been amended to expand and to clarify that. So the proposed wording in the terms of reference has been updated. Since discussing that with the LMC, they have today come back and highlighted a further tweak that they are suggesting. And actually that ties in with the paper because one of the queries was whether we should clarify that with respect to clause 29, where people are attending the meeting and representing organisations, that they would then be able to discuss the paper with the organisations that they represent. So the query really for the committee is whether they would like that further clarification added into clause 29, and then to ask the committee whether it's happy with the revised terms of reference as set.
Thank you, Amanda. Are there any comments or questions from anybody? No. Are we happy to include the latest suggestions from the LMC, putting some words in, about representatives outside the organisation, so that matters on the agenda can be discussed within it? Paveen?
Thanks, Doris. I think I just want some assurance that if representatives were reporting back to their individual organisations, that the personnel that they are reporting back to are also bound by the confidentiality clause?
So the terms of reference, the membership of the terms of reference and the attendee list makes it clear whether people are attending as their role as a governing body member or being a member, or attending as a representative of an organisation or indeed a professional body or somebody with skills and experience of a particular profession. So the organisation is then bound by the confidentiality requirements. So the wording as it is sufficient, but I think if additional clarity is required in terms of specifying that anybody that attends on behalf of an organisation is able to share it with the organisation, then that is fine. But Paveen, in order to address your point, the organisation is bound. It is being asked to comply with confidentiality requirements.
Thank you.
Are there any other comments, questions?
Sorry, Doris, I just have a further one. So it's not about the confidentiality. Did we address the risk section, because that's coming up in the TIA audit recommendation?
Yes, thank you, Paveen. Yes, there is in there. There is specifically, it's mentioned that the risk register is reviewed by the Primary Care Committee.
Okay, so we're happy to approve the tools as currently drafted, with an addition in relation to where people are representing an external organisation. They can discuss it within that organisation, but obviously it is still confidential. And with that, we can approve the revision for it to go to governing body in a couple of weeks' time.
It may not be going to the March governing body. It may be delayed to the April governing body. It's just finalising a few points on that, but at the next available, certainly that's the intention.
So members are content with that? Silence I take as yes. Whilst you're just doing your final tweaking, I think the numbering in under number 14, the sort of under 14A, something went awry with the changes, I think. Can you just check it and to stop other BDI people picking it up?
Yes, thank you very much. No, thank you. It is always helpful when that happens. 14I, did you say?
14A.
A, sorry.
Yeah.
Yes. Yes, I can see what you mean. Lovely. I will tidy that up as well and make the change as per the LMC's request and as discussed.
Brilliant. Thank you very much, Amanda. So hopefully that's it, put to bed for another year.
Yes. Thank you very much. Thank you. Bye-bye.
Thank you. Bye-bye. Are there any other business from anybody? No. And there are no questions from the public. So this is a short and sweet meeting. I will call it to an end.